head, neck, and brain cancers, coming next on Call with the Prairie Doc.
Good evening and welcome to On Call with the Prairie Doc. Cancers that are known collectively as head and neck cancers may begin in the squamous cells that line the moist mucosal surfaces inside the head and the neck, for example, inside the mouth, the nose, and the throat, or they can present as tumors attached to bone or deep within tissue. They can affect the gums, the voice, the box, sinuses, tongue, brain, pretty much any area above the shoulders. We answer your questions as they arrive. Should there be any more questions than we have time to answer during the broadcast portion of this show, we'll be continuing to live stream on our website after the show on our after hours portion of the evening. Make sure to watch that. To view the after hours questions, go to online oncalltv.org and follow the directions there. Get your questions in though early, and so we can do them live tonight. Call 1-888-376-6225 or email us at ask@oncalltv.org. To help with exploring these cancers and answering your questions tonight, I am joined by Dr. John Lee of the Sanford Ears, Nose and Throat Clinic and Dr. Henk Klopper of Avera Medical Group Neurosurgery. So we've got a ears, nose, and throat surgeon, and we've got a neurosurgeon, brain surgeon, and just a lonely old internal medicine doctor in the group tonight. Thank you both for joining us. So John, tell me a little bit about yourself. You were originally from where?
I'm from a small dairy farm in northern Minnesota, and then I went to school in the West Coast, came back for my training, and I stayed on forever at the University of Iowa until I moved here about 6 years ago.
Oh, wow. And you did a lot of research at the University of Iowa.
I did, we still do.
Yep, and you're still involved with research.
Yep.
And so you went to some little school out on the West Coast. What was that?
It's similar, it's named Stanford.
Stanford, not Sanford.
Yeah,
close.
Similar, it's close.
So, the cancer treatments that you are doing primarily cancer treatment. I mean, you're an ears, nose, and throat doctor, primarily trained in that, but you address mostly cancers.
Yeah, people don't want to come and see me.
They don't.
They don't. It's just one of those things. And most of the time, it's it's not the best news always, but we get them through it.
It's really nice to have you here when we need you.
Yeah.
So Henk, you're a South Dakota boy, aren't you? Tell me about where you're from.
Well, I'm an immigrant, actually, Rick. I was born in South Africa, and then when I was a young kid, my family immigrated to western South Dakota. I'm a transplant. And
so a South African, you came to South Dakota, how old?
I was about 11 at the time, 11 or 12.
Wow.
And then went to school out in Phillip, South Dakota.
Phillip, grew up in Phillip, and your dad was a primary care doc.
Yeah, he's still there practicing.
Still
Small
practicing
town doctor.
in Phillip.
Yep.
You think he's watching?
You know, I don't know. He's probably working, actually.
Yeah. So he has a vigorous life of practice, doesn't he?
Yeah.
So, and then what did you do from there?
From there, I went to college in Sioux Falls and medical school at the University of South Dakota, and down to Omaha at the University of Nebraska for my residency training. And since then, I've been back in Sioux Falls at McKinnon.
So you've been here for how long?
It'll be 4 years this summer.
4 years doing neurosurgeon.
Time flies.
I think you were a brand new neurosurgeon when you were on the show the first
Hot
time.
off the press.
Hot off the press.
Yeah.
South African and a dairy farmer from northern Minnesota.
It
Northern?
makes you wonder, did they think that they had to go from south to south?
Yeah, that's it.
Keep the South in the name.
Yeah, you're from southern Dakota, you know. Yeah. So it's an interesting admix because I wanted to have Henk back on the show, and I really, dear friend of ours is also a person who you have cared for, and we have collaborated together on, and I wanted to have you on the show, and I thought, gee, why not put the two, because you do deal with cancers of the brain, not only cancers though, you do other neurosurgical things. What other neurosurgical things do you do?
Right. So as a general neurosurgeon, we deal with brain tumors, other problems associated with the brain, such as brain aneurysms, hydrocephalus, things like that, and then also spine surgery, the most common of which, that also includes some tumors, but the most common stuff is degenerative problems with the spine, arthritis of the spine.
Right.
And then a little bit of stuff involving the peripheral nerves, the nerves outside of the spine, nerves in the arms and legs and so on.
Right, great. So we're going to talk about cancer though tonight, and you deal with enough cancers that
Yes.
It makes you an extra expert. And we're following South Dakota Public Broadcasting's show. Well, it's the national show on cancer that came up. Tell me a little bit about what you thought about that show, John. You had a chance to see it.
I think if you didn't get a chance to see that, I watched every episode, and it's an amazing documentary of where we've come from and where we're going for cancer. And I even from I think it was thrilling for my daughter, who's 16, to watch it as it was for me. So they did a nice job of really explaining it, both in a way that I could still stay interested, and that it was just really good.
Well done, wasn't it?
Yeah.
Hank, did you get a chance to see any of it?
I didn't. I just heard about it, and I'm going to see if I can get it online.
Yeah, I saw the first show, and then I was tied up on the other two. But it struck me how many people had to suffer through chemotherapy with maybe a little bit of hope, and then they die anyway.
Yep.
And there's still a fair amount of that, but the reason that people, and this is the oncologist's point, and I think I'd like to make it because that's the internal medicine side of things, that you only give this cancer therapy, the chemotherapy, to help people enjoy their life, make their life better by sometimes prolonging it and making it easier. Sometimes, though, it doesn't work, and that's the reality of it. But we're better and better as we go, aren't we?
Yeah, and I'm going to disagree with you a little bit there, Rick. And I think that's an internal medicine perspective. I think it's a waste of my time unless I cure the patient. And as surgeons, that's what we look for. So if we can't cut it all out, which in many cases for cancer will cure it, but there are newer therapies that are coming out where it's not just, well, we're going to kind of aim at getting you a couple more months, but and the 60-minute thing was another thing which we were talking about earlier. I mean, there are newer therapies that are coming out that are really going to use our body's own response to cure the cancer. And it may not be in everybody, but when it does work, it's truly miraculous.
The injection of the polio virus in the brain cancer.
That's one that was on last week.
But you're doing other things, aren't you? I mean, you're injecting other viruses into tumors now?
So there's two things. What I will say, it's like this. Once we understood how bacteria made their cell wall, all these antibiotics came out. And
Right.
You're probably old enough to remember.
Yes.
Are you?
I am.
When that people actually died from their bacterial infection?
Yes.
But and it's the same way. There's about 20 different compounds that come out. They're learning now how to allow us to cause a mild autoimmune response, where we use our own body to react to itself for these cancers, and a lot of them have specific changes that go on, either viruses or different proteins that have changed. They've had to have changed to turn bad, and to trigger that response, and it's only going to get better. And the nice thing with those is, in many cases, it's a complete cure. I'm sure you've seen it sometime in your career that these people, we've known for a long time that people can cure their cancer for hundreds of years. We just didn't know how to modulate it safely.
Yeah.
But now that's fairly much more well understood. And I think the hope, I think if you watch that show, the last 25 minutes of it were on immune therapy and how that's going to kind of really kind of change the face. So I think for us, we don't want to just aim at, well, I'll give you two more months. You know, I mean, for me, I don't want to do a therapy like that.
And I'll argue though, there are times when you don't have cure. You don't have that cure, and what you can give them is more than 2 months, maybe another couple years.
Yep.
And I've just watched a friend who finally died from cancer, a Sanford physician friend.
Yep.
And he had years because of the therapy, and we knew for the last 4 years that it wasn't going to cure him, but it gave him extra time.
Long time, yeah.
Hank, we need to jump in and then we'll take a break.
Yeah, you know what I'll say from the brain standpoint is There are other types of tumors that are a little bit unique in the brain that are benign histologically, meaning they don't invade like an aggressive cancer. They don't invade the tissue and spread other places and spread like wildfire. But because of their location, behave malignantly because they can put pressure on critical areas of the brain. And sometimes those can be cured with surgery, but there are also some new techniques that have come out that we can use to treat those cancers where they're not completely surgically accessible that have also been game changers. And specifically, what I'm talking about is what's called stereotactic radiosurgery, which has come a long way, where you can take a focused amount of radiation and very specifically target a high dose at the tumor and spare the healthy tissue that's close by. So there, aside from what you guys were just talking about, there's been some good progress in the neurosurgery front.
Are you thinking about acoustic neuromas in particular? I'm thinking about
acoustic neuromas, meningiomas.
Yeah, but they can be a bad actor where they're at.
Yeah, they pop up in the deepest, darkest nooks and crannies at the base of the skull, and can be very difficult to deal with. But we've made a lot of progress, even just in the time that I've been around in treating those with these focused forms of radiation.
Right. So. Great. Well, we'll take a break now. Let's take a look inside the body to see how cancer comes to be. Cancer is by definition a process like normal cell growth, but when the growth becomes uncontrolled and invasive into the territory of normal cells, destroying all in its path, then that is a malignant process. This is an electron microscope picture of a breast cancer cell. It looks almost like a crab, which is literally Latin for cancer. This abnormal growth starts from normal cells that have been chronically irritated from foreign substances like tobacco or radiation, or from infections like hepatitis C or human papillomavirus, or by lifestyle problems inflaming the liver like alcohol or obesity. And of course, certain families predisposed to cancer by their genetics like breast cancer. Here we see the evolution of normal cells from a small genetic mutation, all over there, to hyperplasia, to dysplasia, to in situ cancer, to invasive cancer. Similar to the earlier illustration, this is a depiction of how cervical cancer evolves from normal on the left to cancer on the right, all triggered by a human papilloma or wart viral infection for which we have a vaccination, by the way. Also, an illustration of the evolution of colon polyps, left to right, benign toward malignant, illustrating depth of spread increasing until the cancer is spreading into other organs. This is a chest x-ray of someone with cancer of the lung, likely a result from exposure to cigarette smoke. Likely it's a primary over here, starting there, and then has spread to the lymph system and then to both sides of the lung, causing a very malignant process. This is a mammogram showing breast cancer. The arrow points to the primary site, and then there's evidence of spread into the breast. Cancer too often is uncontrolled and invasive, spreading into the territory of normal cells. Knowing about this process helps us understand how to protect against and treat cancer. Some weird guy in some scrubs there yelling. But the issue of inflammation or irritation or chronic exposure to a toxin bringing on cancer or of infection, of viral infection, is a very important one. Then the pie chart that showed that 40% of us will have cancer of some kind eventually in our lifetime. We need your questions to have a good show tonight. Would you please give us your calls? We can talk about head, neck, and brain cancers, or head and neck and brain issues, if you'd like, of any kind. Call 1-888 888-376-6225 or email us at oncalltv.org. This is your show. We really need your call. Please give us your telephone calls. And I must say that we were talking about human papillomavirus on the cervix. What about human papillomavirus in the head and neck area?
That's a great question. About 20 years ago when I was at Iowa and I was a young resident, we started noticing 2 different types of cancers that were starting to come. And over the last 20 years, we've realized that human papillomavirus causes cancer, especially in the tonsillar area, almost exclusively. And that rate has gone from a rate of 1 per 100,000 now to 10 per 100,000 in the last 30 years. Nobody knows why, but now it's the most common cause of cancer that I see in the head and neck.
Now, I mean, of course, one thinks is that oral sex that might bring, a human papillomavirus there, but there are other reasons for papillomavirus to be there.
Yeah, what I would say on that is, so the studies have been done, and for certain sexual practices, especially oral sexual practices, there is an increased risk, but comparatively, this virus is very resistant. It could be sitting on the surface of this,
My cup.
It could be on the cup. And we put a lot of things in our mouth, unlike where it's in the cervix, it's very specific how it can get in there. And so I'll say that the data is like, 4 or 5-fold increased risk compared to the cervix, which is on the 100% risk.
Right.
But and so I'll say it's not completely a sexually transmitted virus.
It might be.
Okay, partly, yeah.
And would the human papillomavirus vaccine protect against that kind of cancer in the throat?
Those studies haven't been looked at yet. Most people get it when they're 55. So if you think it's a protein-based vaccine, just like when we give, like you get your shot for pertussis, that wanes after a long time. So I worry that if we don't keep vaccinating, we may not keep that immunity in everybody. But I would still, my kids are vaccinated.
Yeah.
So
so are mine.
Yeah.
Henk, we're talking viral infections inducing tumors. Anything in the brain in that regard?
Nothing specifically that we know about. It's definitely possible, but there's not been a direct link in brain cancer.
Right. Are you doing any kinds of brain cancer treatment utilizing injection of viral infection like the poliovirus thing at this time?
No, we're not. So that's something that's in the very earliest stages of research in humans. That's research that's been going on for a long time and has shown some promise in the lab, and now it's making its way into the hospital and being tested in humans.
Right.
And it's a very exciting possibility. A lot of these tumors, we really haven't made a change in the survival, in the impact that we have with our best treatments in decades, and so it's very exciting.
So what this polio vaccine? What did the study show? I mean, what were the numbers?
Well, so they're in the phase of the trial where people are enrolled that have had the normal treatment, and then the cancers come back, and so it's a very specific population of people. And the studies that are being done right now, the early stuff that's just come out that was recently on television, is from the first phase, which is to figure out the dosing.
Right.
It's not designed to see how well it works and what the cure rate is going to be, but they've had some exciting findings, what I would call preliminary findings in that study.
And the percentages are up there, way up there.
Yeah, I think it's about 50% that they've seen so far, but
that's
that'll be ironed out as time goes on.
Compared to the 10% or 5%.
Yeah. Yeah.
Huge.
It's huge.
So, I mean, you think about it. There's a lot of people who question science and are reluctant to believe in science and the advancement of science, and particularly in oncology. Boy, the things that have happened in my lifetime in particular.
Yeah.
I mean, the cures for testicular cancer, a friend of mine died of testicular cancer. The cures that we have for acute myelogenous leukemia that was a for sure death sign. The cures that we have for breast cancers that were, I mean, it just goes on and on.
Yeah.
We appreciate your calls. Give us your calls if you could. Some people who are diagnosed with cancer react with as positive an outlook as they can under the circumstances. Not being Pollyannish, but having a realistic view of a good outcome potential. This attitude has many benefits for them as their treatment progresses.
Originally, when I was talking to the doctor, I was having some issues with the right side of my ear. Kept feeling the nodule there. They kept putting me on medicine, and the nodule would go away, and about a month later it would come back. And then I'd started feeling more nodules, and it's like, this, not right. But after they did aspiration, and they're just going to do an exploratory surgery, which was supposed to last about an hour and a half. And it ended up being about a 6.5-hour operation. While they're in there, they found 10 lymph nodes that were inflamed, or after the biopsies had the cancer in it. One of them, according to my wife and the doctors, was about the size of a small softball. Chemotherapy, side effects, symptoms, initially it wasn't really anything. It kind of felt like catching a cold like I got now. But the longer we did it, after about the 4th, 5th time, then you can actually start to tell that it's taking a toll on you. You get tired, and you're not tired just for a few hours, you're tired for 2-3 days. That was rough, you know, especially when they're doing it on your throat. You have a hard time eating anything because it hurts so darn bad. Even today, I haven't had radiation since December. Anything that has a vinegary taste to it or very spicy, I can't eat. It burns my throat. I sleep a lot more. You know, you get wore out, little colds like I got now, it knocks you out in 4 hours. You're very, very tired. Pushing yourself too much, again, you get very tired. That's about the only thing that's bad about it right now. Cancer is not scary. It's just another thing we have to go through. I guess the only other thing I gotta say is in my mind, if it weren't for the Breast Cancer Organization, the national organization, cancer research and cancer treatments would not be as far as it is today for my type of cancer or anybody else's type of cancer if it weren't for that fact. I do believe that's one of the primary reasons I'm alive still, is because it's so prevalent, everybody's so aware, everybody keeps pushing and donating to that. Every little dollar you put in to help helps. Not just breast cancer, but cervical cancer, pancreatic, intestinal, head and throat. Everything leads to a new breakthrough for something. So just keep giving, keep helping.
And that was a giving and loving thing to do for us, Troy. Thank you so much. He spoke about the issue of giving and donating and cancer organizations. And Henk, what's your take on that kind of a thing happening?
On donations to cancer organizations? Yeah, I think that's a fantastic thing to do. I think you, like with everything, have to be careful and know what you're donating to. There are unfortunately some organizations that don't use much of the money that's donated for cancer research, but there are some very good organizations.
Which is your favorite?
Well, the United Way does some stuff, and a lot of that stays locally. But I think oftentimes, and this is just an opinion, donating directly to the institution where research is done often ends up being the best, most efficient use of those dollars.
Right. Any takes on that, John?
I agree with his last comment 100%. I mean, I think if you know the individual and can direct the dollars with the lowest administrative costs, a lot of those times are the direct, and then it benefits the community too, because that goes right back, hopefully, to bring better cancer treatments
locally.
Yeah. And that's really what we need, especially in South Dakota.
And we're doing the research both at Sanford and McKinnon, Avera. So as a guy who came here and didn't see a lot of that when we all started, and have watched the growth, particularly of the research in cancer in this state, I want to tell you personally how much I appreciate the work that's being done, both of you. So we'll go on to some questions. We've got good questions. 70-year-old from Madison, comment on poliovirus in 60 minutes. What are your thoughts and opinions? One more comment from you. You're hopeful. You think that it's good. Henk just did speak to that polio, but it's going to be a while before that comes to us.
It's an amazing result. I mean, and it's not just for. I mean, that was just one. These things are coming out. Like for us, we have one that's going to start within the year. It's a virus that targets the HPV virus, that what we just talked about.
Right.
So we have the exact same thing. It uses a little bit different virus, and these things, what it's doing is it's triggering that your body's response to that virus. You just do it safely, and it's exciting. You know, I mean, it's just you can tolerate a little shot compared to a lot of chemotherapy or radiation, or a bad surgeon like myself.
Oh,
you know
yeah.
what I mean?
Yeah.
So I mean, it's just it's really cool. So I guess I would encourage people to look up the data and keep following it. And the nice thing, it's going to be happening here.
Yeah.
In South Dakota, you know, so I'm sure both organizations, I know our plans. We have several trials open already, not for brain, but for head, neck, lung, and breast, and these are having amazing results. If I showed you the CT scans, these people have metastatic disease and their tumor is melting away, and it doesn't come back.
Wow. I mean, and that's
it's like
our immune system is doing the trick.
Yeah, and they don't get sick. I mean, if you had to pick a way to get rid of your cancer, I mean, I don't really want to see the surgeon. I don't want to see the radiation oncologist.
Yeah.
I don't want to see the medical oncologist because they make me sick. And it's like tolerating a viral infection.
Yeah.
And I think also exciting, if you take the 30,000-foot view, is that, you know, this probably is the dawn of a new era in the treatment of cancer in general. You know, these immune therapies, different ways of stimulating the immune system and using the person's own immune system to fight these cancers. So I think we're on the brink of a major step forward in the next 10, 15, 20 years.
Yeah. Wow. Here's an 82-year-old from Brookings. Daughter fell on the eye, second-degree concussion, is wondering if the injury would cause a cancer. Concussion, danger in irritating the brain, causing cancer. You ever see concussion-induced or recurrent concussion? Cancer higher in football players and...
No, there's not any clear link between brain injury and cancer. There has been some question in the past about a benign brain tumor called a meningioma, which comes from the lining of the brain being related to a knock to the head at some point, but not a strong link. So, short answer, no.
No, that's good. Caller has a bone marrow transplant. Doesn't know if this is related. She's had squamous cell papilloma virus on her tongue 4 times. Can she stop it from reoccurring? So she's got a wart on the tongue that reoccurs, and she's had a bone marrow transplant in the past.
So this is a hard one because she's probably immune suppressed.
She's immunocompromised.
And this virus lays around even in normal tissue, and so it's going to be difficult. The only way to really get it is if her immune response gets better, and it may clear. I mean, you can locally cut them out, but you know, it's like any viral infection. It needs to get an immune response to it first.
Boy, I don't know if you've ever had, you don't have to deal with warts. I'm a primary care guy, right? I've got people come in with warts on their foot. I mean, debilitating, miserable warts on their foot. And you keep delaying to hoping that the immune system will kick in. One of the things you can do is you can burn it or freeze it or irritate it and then hope that the immune system kicks in. But wart treatment, I mean, you can do a very, very, very expensive kind, or you can use a little bit of a banana peel upside down and some duct tape and
potato
and it works, or it doesn't work, just like the fancy laser therapy.
Yeah.
How accurate is the cure for polio vaccine? Well, we've addressed that enough. Caller's mother had poor fitting dentures that caused inflammation, which caller said caused cancer. She did not get her mouth checked until she had stage 4 cancer, causing her death in 2 years. Please stress that people with dentures should have regular oral checkout.
That's a good point, because most people, now the dentists do the screening for us, and so they'll call us and say, listen, we have something. Somebody without dentures still needs to get at least looked at. And what I guess what I'd tell them is anybody has a sore for more than 2 weeks. So everybody gets these little aphthous ulcers, right?
Yeah.
You get a little sore in the tongue, but it should go away in 2 weeks. And if it doesn't, go in and see your local doc, and then get it seen.
A sore that lasts longer than 2
weeks is the cutoff.
I kind of like that. How often is surgery done on the brain for AVM, AV malformation? What is an AV malformation?
AV malformation is a type of blood vessel abnormality that we're born with. It's an abnormality that forms in utero. And it can sit there for a long time, and the person doesn't know that they have it until it causes some sort of symptom. And the way that can happen is it can cause a seizure by irritating the brain, or it can bleed and cause a stroke. And so surgery is done for certain AVMs that can be taken out safely, and there's a lot of stuff that goes into that. I won't get into all the details.
Right.
That's another example of where the stereotactic radiosurgery, the very specific, focused, highly accurate radiation is very effective. There are also some newer techniques that don't work great by themselves, but in conjunction with surgery or the radiation, by treating it from inside the blood vessel, can be very helpful.
So those are AV malformation things. Do they ever turn into cancer? Do the AV malformations?
No.
So do they ever burst and then you have a bleed and then it kills the person?
It can, yeah.
And that's part of the reason why we go in there. Are we doing these little spring-like things and put them in? How does that work?
So the coiling is done for aneurysms of the brain, which is a little bit of a different problem. Now you can have aneurysms that are associated with an AVM, and sometimes that can be treated with coiling in addition to some other treatment for the AVM. There are also glues and particles that they can inject into the AVM to block some of the blood flow. Right. And then that's done in conjunction with the other treatments.
And the word AV malformation means?
Arteriovenous malformation. So it's an abnormal connection between the arteries and the veins.
Okay. Well, it can start with a little bump and some watchful waiting, but if it continues to grow, become painful enough to cause concern in the patient and doctor, then it is time to take the next step.
I had a lump started to develop on the side of my cheek, just in front of my ear. And didn't really think too much of it. There was a small lump there, and it was hard and hurt a little bit. But anyway, my best friend is also my doctor. And so I had him check it, and he felt it, and we monitored it for a while, And after, I don't know, a couple of months, it seemed to be growing a little bit. And I was concerned about it, and so we had it biopsied, and that was early in the summer. And it came back benign. They just did a needle biopsy on it, and it was benign, so I quit worrying about it. They did a scan and found a few more lymph nodes down in my neck, one or two that looked like hot spots. And so then they did another surgery and took a bunch of lymph nodes out of my neck. Shortly after that, then they did radiation. I didn't have to have any chemo. They thought they'd gotten all the cancer, but they did want to do radiation just to make sure that the cancer was gone, that they hadn't left any little. All they have to leave is one cell, I think, and pretty soon you've got it again. So they radiated the side of my face. She said about up to my eye, and then all down here and down my neck. They radiated that side of my head. I've got some dental work on that side, some crowns, which are mostly metal, and it burnt quite a hole in my tongue. They said it was scattered. The radiation was scattering. But anyhow, it burnt quite a hole in my tongue, and I couldn't eat anything. I suppose I went from Thanksgiving until, it was way past Christmas before I could eat anything. I lost 60 pounds. I don't have any pain, none at all. I still don't have much taste. Everything kind of tastes the same. And still a little bit of metallic taste in my mouth, but the taste is slowly coming back. Well, the doctors, they've got it figured out. You know, there's still a lot of people that do die from cancer, but I think they've probably neglected it or denied it. You know, they might be having some symptoms and they don't say anything to their spouse or to their children, and they don't get treated until it's too late. So get it treated, get it taken care of.
And I don't think Brian would mind that I would share that his PET scan was negative, no spread, and we've got a cure. I mean,
That's
it's
great.
a great percentage chance of a cure, and you know, when it's not a good, easy thing to be a doctor in a smaller town, you know what I mean? Your patients are also your dear friends. So we're so pleased, and we thank him for saying that. And the point he made on that last ending point is, if you got something that's not quite right, don't cover it up, but get it checked. I think that's a good point. Any other comments that you would make? You take care of him.
Yeah, I guess a couple things is, you know, the lump that doesn't go away like we talked about, but also if like you have a sore throat, and you know, we all get sore throats. If it doesn't get better with the typical course, just ask. And I think that's a great time to trigger for us to take a look and see, because we'd rather treat them when they're small than when they're big. They're much easier to treat when they're smaller and localized than when they get to be very large.
Right. The next question is, 63-year-old from Alcester had a lymphoma removed from her jaw 7 years ago. What are the odds of it coming back? Lymphoma is a different character than the last two cases that we had on. And lymphoma is almost more of a whole body thing. It's not something you typically treat. You see lymphomas in the brain, though, don't you, Henk?
We do, yeah. It's not terribly common, but we do see it. That's one tumor where surgery is not, it's not part of the treatment. Where we get involved is biopsy to get the diagnosis, typically. And sometimes putting in a port to be able to put chemotherapy directly into the spinal fluid. But we do see that not infrequently.
When people have a lymphoma, you know, it's in the lymph system, which means that it's in the blood, it's in the lymph, it's in the whole body.
Well, there is an animal called a primary CNS lymphoma, which is one...
just in the brain.
It's kind of a strange thing, yeah. It shows up just in the brain and not in the rest of the immune system. And
doesn't pass the blood-brain barrier?
It's inside already.
So it's there.
Yeah.
So talk about the blood-brain barrier.
So the blood-brain barrier is this concept. It's essentially the way that the blood vessels, the microscopic blood vessels of the brain are designed to help protect the brain and keep out toxins and bad stuff. It's much more selective about what it lets through than the blood vessels in the rest of the body. And actually in some of the cancer treatments, that's a major problem because you can't get the chemotherapy, which is a type of toxin, into the brain where the tumor is.
It has to be in a higher dose to get it there, but it burns everything else out poorly. I mean, sort of, it seemed like with Cinemet for Parkinson's disease, you can't get the L-dopa into the brain, so they had to trick it with a blood-brain barrier trigger called carbidopa.
Yeah.
So the blood-brain barrier is an amazing thing. It protects us. But in the lymphoma of the brain, does it keep it from going elsewhere?
And that's the reason, actually, that I mentioned that port that we have to put in to put chemotherapy into the spinal fluid. And that's the way that you bypass the blood-brain barrier. If you give the chemotherapy in an IV, like you typically do for other cancers, it doesn't get, the brain doesn't let it in to get to the lymphoma.
Yeah.
And so you have to inject it directly into the spinal fluid.
That's fascinating.
Cool.
Talk about detection of non-Hodgkin's lymphoma, blood and lysis, what to look for. Well, we're talking lymphoma. It's really non-Hodgkin's lymphoma is one kind of lymphoma, and then there's Hodgkin's lymphoma, which is another cell type of the lymph system. Any comments that you want to say about non-Hodgkin's lymphoma? We've just discussed it.
Right. All the lymphomas that we deal with as neurosurgeons are non-Hodgkin's lymphomas. The Hodgkin's lymphomas, that's a little bit outside of my area, but that tends to be in the chest and abdomen and different parts of the body.
And I guess the only take-home on non-Hodgkin's lymphoma is when there is a lump. And you deal with lymphomas and lumps. You catch lymphomas. When you find a lymphoma in the head and neck area, what do you do?
So, yeah, there's a couple things. You feel your groin when you shower, under your armpit, and in your neck are the most common places to feel them. And again, it's if they feel like a shooter marble or a quarter-sized marble.
Instead of the regular marbles, it's a shooter.
Most of the lymph nodes are so small that you can feel them if you know how to do it, but they're pretty hard to feel. These look a little bit firm. The other thing to watch for lymphoma is there are these things called B symptoms. I don't know why they're not called A symptoms, but they're night sweats, unexplained weight loss, itching, and kind of general fatigue, feeling like you got the flu, and nobody understands why they come on fully, but those are the things too for lymphoma and recurrence you got to be careful about.
And you have a clue with the CBC. But if I told you how many patients,
normal CBC.
Who did I see today? I had a walk-in clinic today, right? I saw 20 people with. Half of them had fatigue, so you got to. They didn't
be careful.
They didn't have lymphoma. One had gallbladder disease, another had pneumonia, and I mean it's a clue for a lot of other things. Talk about meningioma, benign tumor. Was wondering if she should look into the radiation therapy that was mentioned. Meningioma. Does a person need to have a benign meningioma treated?
It depends on the size, the location, and whether or not it's causing symptoms. A lot of times we end up just watching these and getting MRIs at certain intervals just to see how fast it's growing. They're typically very slow-growing tumors. And it's a very common scenario where someone is found to have one because they bump their head and they get a scan for some other reason, and then you see this thing that wasn't causing any symptoms. And so we end up watching them, and they never end up causing a problem. So they don't necessarily have to be treated.
Okay. All right. So one caller said, why is the United States so far behind in treatments for cancer compared to Europe?
I would say that the United States is not far behind Europe. I guess I wouldn't agree with that statement at all.
I would disagree as well. I'd actually say more of the therapies are coming, or at least equal or more, coming out of the States as they are in Europe.
Well, one of our pre-med student researchers in the back room got that question and looked it up. And let's just take brain cancer.
Okay.
United States, the 5-year relative survival rate or percent for selected cancers among individuals aged 15 or older in select counties. Brain cancer in the United States, 26%. This is 5-year relative survival rates. 17% in England, 18% in Denmark, 20% in Austria, 19% in Poland, 22% in Belgium, 22% in Germany, 17% in Spain, 21%. So the survival rate is higher or better in the United States in the brain. That's a better number than the rest of the place. Breast cancer, 89 in U.S., 77, 77, 80, 73, 77, 78, 80, 82, 71, and we're 89. And if we did, let's see if I can find Hodgkin's lymphoma, 84 versus 78, 79, 79, 78. And if I can find head and neck, let's see if does it have head and neck. Thyroid, 97% in the U.S., 77% in England, 76, 84, 82, 76. So I think we've got data that suggests otherwise. Now this is, who knows where the source is, but the truth is childhood cancers are the same way. It's close, but maybe even better in the U.S.
And I think that comes, it's a good point to make too, is if you look at how much we've invested as a country in cancer research versus others, it comes as a result of that. It's the places that put the money in and to do the research and to the trials that we've been talking about really are what are going to make the most advances, hopefully.
Right.
And the access to diagnostic equipment in the U.S. is vastly different than a lot of these other places also.
Some would argue too much.
Too much.
Yeah. For a while, there were more MRI scanners in Sioux Falls, South Dakota, than in England, the whole country.
Yeah.
So that's also part of it.
What about the issue of cell phones and brain cancer? Because I can tell you that my earlobes are thicker on my right side because I know I've burned my ears because it gets hot sometimes, and I've had long conversations, and my earlobe if my ear auricle is thicker on the side that I've got that radiation going on, is there evidence? I wouldn't be surprised if there was evidence. What does the evidence say, Henk?
The vast majority of the evidence indicates that it does not. Now, we haven't done studies that are good enough that I would say this is 100% surefire no. But the nutshell answer, based on all the studies that have been done, would be probably not. And if it does, the increased risk from using a cell phone is tiny.
Right, and so
probably not.
So
Stop smoking instead of...
Stop smoking, because there's the real cause. So both of you are dads. Right. So they're lost your good excuse to say, honey, you got to get off the doggone cell phone, because it turns you into it gives you cancer. Right. What is the most common cancer of the head and neck do you take care of, John?
The most common one now is a tonsil cancer. So it's going to be a sore throat and that tonsil that's going to show up as. And so
tonsillar cancer. But now, I see people who have crypts. They have tonsils that have been infected multiple times, and so they have these little caves that are scattered over the tonsil. And if you look at it, oftentimes there's little pockets of kind of pus-like in the crypts, and I don't care how clean they are, they're always going to have little crypts in there with a little bunch of junk in there. What do you recommend? Do you take those tonsils out, or is there a risk for cancer in that group? Or
I'm pretty conservative. What I tell them to do is with a soft toothbrush or a water pick to that area. Even though I'm an ENT doctor and I know most people or ENTs make their money taking tonsils out, it's painful. All I can say is that if you don't want to be able to swallow, it's painful, and it's also a risk of bleeding. So if you can take care of it without having chronic infection, that's the best. And there has never been shown a risk. I actually asked the question, does that increase your risk of tonsil cancer? And there's some data from Sweden that suggests no.
No?
It's not the lack of tonsils or the presence of tonsils. Now, there's only been one study and they looked at, but it's possibly no.
And I have another question about the use of mouth tobacco. Instead of smoking, it's chewing tobacco or pouches or snus or all these things. I suppose, they're going to expect you to say, oh, it's bad, don't do it. Do you think that we've got 30 seconds left, do you have strong data or comment about...
Smoking, huge risk. There's certain types of like Copenhagen or whatever, the rough stuff you just lay in there, that compared to smoking, it's so much safer. It's maybe 1.6 relative risk, which is very little. And then there's a certain type of Swedish tobacco, there's no increased risk, because it's the fermentation process of the tobacco that causes a little bit of carcinogen. Because it's just like putting lettuce in your mouth. Right. Is lettuce not safe? I don't know, but these are just,
wow.
That's been a little, so again, if you can't, don't do it, but if you have to switch, do something different.
All right, we'll be back right after this.
Quit smoking, and in just 20 minutes, your blood pressure returns to normal. In 12 hours, carbon monoxide levels in your blood drop. In 48 hours, your sense of smell and taste improve. Within 2 weeks, your lungs work better, you heal faster. 9 months means more energy, fewer illnesses. And in 5 years, your risk of heart attack is half of what it is now. Take a deep breath. You can do this.
There is something about that word cancer, the big C. When the pathology report displays those abnormal type cells on biopsy and the report spells out those 6 black letters, then, whether it is a simple treatable condition, or one that will most certainly predict an earlier death, the patient hears cancer and it changes everything. Through the years, I've had to inform too many patients about a new diagnosis of cancer, and have learned there is often a paralyzing fear that comes with the word. Due to advancements in science, many more people with cancer are surviving than when I started. Still, when I have had to say to any one of them, "You have cancer," often the word cancer is the only word they will remember for days. And so I always plan to keep readdressing the topic until plans can be clarified. Unfortunately, some people who hear the word cancer come to face their mortality for the very first time, even when the chance of cure is good. I dare say this goes for too many of us, resulting both from unrealistic expectations in this scientifically advanced world and the cover-up of the dying process in this everything is going to be all right society. This week, a friend told me she and her husband were preparing to sell their house by thinning out their stuff collected over 15 years and remodeling with that new carpet they've needed for a long time. It reminded me of what a realtor friend once said, that he keeps his house ready for sale at all times. Why not put in the carpet, paint the bedroom, fix the step, so that he can enjoy it right now? In a similar vein, I have heard it said that every once in a while, perhaps yearly, we should all have some kind of significant brush with death and then be rescued. Maybe that would help us to get and keep our house in order. And then, when each of us has our turn to cross the river into that land of the sweet by and by, we can feel what the young neurosurgeon Paul Kalanithi said before dying of cancer. "I have found a joy, unknown to me in prior years, a joy that does not hunger for more and more, but rests, satisfied in this time, right now." We shouldn't have to come down with cancer to get our house in order. Well, this brings us to the end of our show this evening. I sincerely thank our fabulous guests tonight, John Lee and Henk Klopper. Our friends at the South Dakota Helpline Center are hosting a 5K run walk at the SDSU campus in Brookings on Saturday, April 11, to raise funds and awareness of suicide prevention. For more information or to register, go to helplinecenter.org or call the 211. And join me because I'll be running. Mark Twain figured the importance of your head like this: what a wee little part of a person's life are his acts and his words. His real life is led in his head and is known to none but himself. And until next time, from all of us here at On Call, stay healthy out there, people.
The old saw says you are what you eat, but sometimes what you eat doesn't get along with your body, or your body has a difficult time processing what you eat. Stomach and colon issues. Next time On Call with the Prairie Doc.
Hello and welcome to On Call After Hours, where we answer the questions we weren't able to get to during the broadcast portion of our show. All of your questions are important to us, and we want to answer as many as we can for you, so thanks for hanging on afterwards.
Oh, that's great.
A 61-year-old man, his football game got spiked. The spot is still sore. He's wondering if it could develop into cancer. So he's 61, and he was spiked when he was in high school, and it's still sore. Take-home message?
Probably won't cause cancer.
No.
So it's just sore. It's a
Sore,
ligament.
it's probably an old injury, ligamentous injury. Yeah.
Unless it starts swelling.
Yep.
Husband passed away from supposed squamous cell cancer. It started in the penis, developed further in pancake-like shape, and eventually traveled to his brain, causing blindness. Comment on the progression of this cancer. So squamous cell cancer can occur on any part of the skin. Penis is irritated there on the foreskin, but any squamous cell cancer of the skin can metastasize to the brain. What do you do in those cases?
Same as for the other tumors. It's for the squamous cell type of tumor, it's much less common for it to spread the way that the other cancers do, the adenocarcinomas and so on, which is through the lymphatics of the bloodstream. Most commonly what we see with that is they directly spread from somewhere, start somewhere on the head and spread directly into the skull.
But you deal with skin cancer or squamous cell cancers from the mouth that spread to lymphs and so on.
Yeah, brain isn't the most common. He's exactly right. The only way it can spread is sometimes going back along the nerves that then track up and follow. They can kind of like following the road back to the brain. But most of the time it'll spread to the lymph node. Or the lung is by far the most
The
common.
squamous cell lung.
It would surprise me even with this one that it didn't spread to the lung and then brain. It can, but it's rare.
So a lot of, how many of your cancers of the head and neck are squamous cell from mouth or skin?
Oh, about probably 80%.
Really?
Yep.
And they go lymph node in the neck?
It's kind of like
or?
an army. There's a base, and then there's the first post, second post, and it keeps spreading down.
All right. 59-year-old from Pierre, caller has lumps in the lower jaw behind bottom teeth for over 15 years, fairly large. What might they be? Lumps behind the teeth.
They're benign, little bony growths.
Yep.
And they happen with age. There's a specific name for them. I won't say it, but they're completely benign. The only thing they make it is a little hard to fit dentures on.
Yeah. What about torus pallidus?
That's exactly. It's either tori mandibuli or torus pallidus. It's the same thing except for growing the hard part of your palate.
And people have these big, huge lumps that look dangerous on the top of their mouth, and they've been there for years. Totally benign.
Yep.
60-year-old Westington, what are the signs and symptoms of a brain aneurysm, Hank?
Unfortunately, not enough. Most of the time that a brain aneurysm is discovered is when it ruptures, which then it causes severe headache and coma, and that's a very dangerous situation.
But they go for years and years with nothing.
Yeah.
And how do you pick it early?
Rarely they can get big enough that they act like a tumor and they start causing problems from pressing on some part of the brain. That's less common. Now, what I would say about that is anyone that has a headache that starts suddenly, especially with physical activity or straining.
Thunderclap headache?
Starts like a thunderclap, like a lightning bolt, worst headache ever, and sticks around for a few days. Should go be seen. Sometimes you can have these sentinel hemorrhages, which isn't, it's kind of a milder form of bleeding, but that increases the risk that in the next few weeks it's going to really blow.
Wow.
And so any headache that sticks around for a couple of days, that's unusual, starts suddenly, should be seen.
Great. What percentage of pre-cancer skin lesions are frozen off, and how successful is it? You have a comment about skin cancer?
Most of them are probably frozen off or treated. So it's pretty rare that they progress.
Right. I mean, I do it.
I'm sure you do it in the office. Yeah.
I mean, I bet 10% of what I do. I mean, I see these skin cancers on their face, or pre-cancers, and I'll use cryotherapy all the time. And I mean, you know, you can clean, after a while, you can clean off their face, and they have a decent-looking face again. And then there'll be one that just doesn't want to go away. If you freeze it a couple times, you better scrape it off or excise it.
Yep.
And some of those will spread.
Some of them do, yeah.
I think the data on scraping it off, freezing it off, excising it widely, it's like 3 to 5% will spread. Whatever you do, still can spread. 63-year-old Freeman was wondering about rheumatoid arthritis, fibromyalgia, amyloidosis would increase her risk of cancer because she has a decreased immune response. Do you think that, number one, I don't know that there's any data to say that these people...
There is actually. So they do have a higher incidence of mostly lymphoma. And it has to do with the regulation of the immune response. So it's kind of the misregulation, but it's not like dramatic. But with autoimmune, some of those autoimmune, it's
can increase your particularly your blood
type cancers. Yep.
Well, and then you start treating them with immuno agents.
Then that could be it too.
There you said that. What are the chances of prostate cancer after a needle biopsy spreading because of the needle biopsy? Hank, do you have any comments about that? You do needal biopsies all the time.
That's the other end of the body.
Yeah.
What, it had nothing to do with the prostate, he said. Why are you asking me this?
I've on purpose steered my career away from that area of the body. Yeah. So I am not the best person to answer that question.
But you do needle biopsies of cancers. Do you ever see cancer spread along the needle biopsies area?
No. With the brain cancers, you don't see that. That'd be unusual.
There you go. Comment on your top 5 things within your control to help prevent cancer.
Don't smoke.
Agreed 100%.
That's number one. That's number one.
Alcohol, if you drink it, do it in moderation. It does increase your risk, but it has to be quite a bit, which is good.
All right. My number 3, if we're talking head and neck cancers, I would say don't leave skin lesions alone. To grow, get in and be seen. Many of them can be treated with a little cryo or scraped off, and then you have less chance of it spreading.
The other thing is this whole tanning bed thing. I don't know what you think about it, but the data is very clear that it dramatically increases your risk of skin cancer. So, I mean, a little bit of tan probably in the summer we can tolerate, but boy, that's a huge UV load that they get every time. So
now, correct me if I'm wrong. This my understanding of that is that melanoma actually is the least associated with UV exposure.
Correct.
But still, maybe is that the?
I think that's what it says. I think that's it. The highest risk is even the basal cells.
Yep.
But it's interesting. Basal cell cancer doesn't occur that much in the black people, and they have this, and their cancers occur on scars. So that was top 3. That's good enough, I think. Here's 2. What with the odds so high for ending up with cancer, is it just a crapshoot, depending partly on your genes, and partly what you're exposed to? Statistics are rather alarming. What do you and your guests do for cancer prevention in your own lives?
The things we just discussed. And I will say part of the reason that we are seeing so many cancers is because of the progress that we've made in medicine over the last century, and people are living so much longer. So you have more time to
catch that cancer.
Yeah.
It's an older age disease. I mean, the longer you live, the higher risk you have of cancer.
Right.
I think to put a point in prevention is really important here, though, too. So, I mean, getting your colonoscopy, especially if you have a history of polyps. I mean, these are the things, if you can prevent it when it's more of a benign, doing your PAPs, and think what Pap smear and stuff did for cervical cancer in the U.S. I mean, I think there's certain things, when your doctor, when Dr. Rick Holm recommends it for prevention, do it. Because those things, we wouldn't do it as a system if it wouldn't be beneficial. So,
I also would say that the idea of getting the viral vaccine, the cervical viral, the human papilloma virus, for goodness sake, that is a lifesaver. And it may well be a head and neck cancer.
It could be down the road,
One thing that I'll add to that is, you mentioned colonoscopy, and really, there almost should be no colon cancer if everyone got a colonoscopy.
Only a third of us are doing it.
There's some recent stuff that's come out about people who do smoke or have smoked in the past that screening for lung cancer with CT scans on a certain interval.
Yeah, do you have a thought on that?
I don't know much about it because, again, it's not exactly in my area, but I just happened to see some of that recently, and it's just sort of caught the highlights of it.
But a CT scan is 100 chest X-rays.
There's some radiation.
There is, and certainly people at high risk who have a family history of cancer and have been a smoker. What do you do? You find a lesion on a CAT scan. I've done this more times than you can know, And you go, what do I do? Now am I going to biopsy that? Okay, that's a major risk thing. Well, let's just CT it again in 6 months.
Yeah.
Oh, well, it hasn't changed. Now, are we okay to wait another year? It just adds to the cost and the complexity of it. So I'm going to wait on this CT of the lung. That's a good question, though, or a good comment, and I'm not right there yet. Okay, so I think, I'll say this, because I haven't said it yet, and I always say it on one part of the show, there's nothing that prevents illnesses more and better and more effectively and more enjoyable than a regular exercise program.
Yep.
And it has been shown to prevent certain cancers, particularly colon. And so I'm going to throw that in.
And it's true. I mean, I think one of the epidemics we're seeing now is completely related to our obesity and lack of exercise. That's a really good point. And the data is very clear. Breast, colon, several of them are completely related to your obesity index.
Well, and your lifestyle, too.
Yep.
So along those lines, are U.S. citizens at statistically higher risk than most? Is that environment and lifestyle? And the answer is, I don't know the answer. I don't think we know the answer, but we do have a better cure rate, or at least the same cure rate.
Yeah, there actually is a little bit higher incidence for brain cancers in developed countries compared to developing countries, but
Really?
That's a statistical anomaly, most likely. People in some of these countries, there's less detection, and in some of these places, people live a lot shorter life.
Yeah, there you go. So, okay, my last question to each of you is, so what take-home message you want to make absolutely sure that we say tonight that needs to get out there?
You know, of the things that we've discussed, I think the preventative things, that's probably the most important. The not smoking, exercising, and getting a colonoscopy. If you do those three things, you're cutting your risk significantly of having some of these problems.
Wow.
I think those three things are, you know, if there's just three things that you're going to do those three.
All right.
And I think two things. One is, especially for head and neck, if you have the symptoms we've talked about, go get seen. I mean, and sooner rather than later. And the second is, I think there's hope, and there's going to be better hope as we move in the future. And I think that's a key, is that you heard the two people tonight on the television, and I think both of them, they went through, it's a painful process, but you know, for the most part, I think, like you said, it's nice to have a negative pet, so it's good to have them around longer.
Yes, thank you both for joining us and answering these questions, and thank you for joining us on our website. We appreciate all of your questions and the opportunity to answer them. And until next time, from all of us here at On Call, stay healthy out there, people.
Funding for On Call with the Prairie Doc is provided in part by
Avera is a proud sponsor of On Call on South Dakota Public Broadcasting.
Larson Manufacturing is proud to support On Call Television as it continues to open doors for important medical information.
And by the South Dakota Foundation for Medical Care.
the Medicare Quality Improvement Organization for South Dakota.
Additional funding is provided by
Aberdeen Asthma and Allergy,
Brookings Health System,
Dakota Allergy and Asthma,
Dakota Care,
Dakota Dermatology,
the Orthopedic Institute,
Physicians Care Sanford Clinic Community Service Committee,
and the Swiftel Communications.
Closed captioning for On Call with the Prairie Doc is provided by the generous support of
Avera,
Brookings Health System,
and the Fishback Financial Corporation.